Hello people. My name is Dr. Shahbaz Ansari. I belong from Karachi, Pakistan. I recently cleared my PLAB 2 and got my registration and awaiting for my UK journey to be started. As far as this session goes, a lot of people, a lot of doctors, and even me, when I was doing my PLAB 2 preparation, I struggled from this thing called approach, how to approach the patient, how to approach the simulator who happens to act like a patient. Like, should I be a bit calm? Should I be a bit persuasive? Should I be a bit more aggressive? Should I be like, overall, what is the approach I should do? Because there are multiple scenarios. There might as well be from the academies that you have taken and from the things that you've heard. And even if you jot down every case individually, there are like hundreds and hundreds of cases. But there were people who told me you need to have a different approach for this kind of a patient and a different approach from that kind of a patient. But all in all, this approach did not work for me because thousands of cases are there and I cannot happen to have thousands of approaches, because by the time I tend to incorporate that particular approach on that particular case, I might even forget what the approach was. So after all the practice that I did, which was around 2 to 3 months, the nutshell of the process was I incorporated this one approach that I would alter according the way and make a roadmap, make a skeleton of the whole approach, make a skeleton of the whole consultation, and I would just change its in bits accordingly, because there will be people, there will be patients which would need a bit more persuasion. There will be patient which will give you all the information at first, and they will be patient with, and you might as well get patients with learning disability. So what you're going to do there, and at times they've got specific concerns and stupid concerns, stupid questions, and if you don't have a foolproof, a bulletproof approach, you can miss on very important stuff, and you can at the end of the scenario, when the session will be ending and you'll have like a bizarre concern of the person and you don't have any time, and you'll be so much stress, they will actually you might actually clear that station, but that particular thing will actually affect you on the consecutive stations. So that is the reason building an approach, building a skeleton, building a roadmap is very important, because at times the patient tends to steer you according to your will. Like, for example, when it's a history taking station, if you ask a person that, could you please tell me how can I help you? He will tell you all of the stupid stuff. He will tell you all the irrelevant story, which are not even, concerning this scenario. So what you're going to do there? What are the things that you have to pick up? And history taking stations are relatively easy, because at that station, the patient does the talking. Whereas the counseling station, where you are doing all the talking, but you have to have all the particular concerns, all the questions, all the queries that the patient might actually throw at you later on. So you have to manage it accordingly. And the clinical skills, the management, the history taking, the data gathering, and the IPS, everything is supposed to be managed in that 8 minutes plan. Starting from your hello till your thank you, it's absolutely impossible to complete everything in that 8 minutes in order to complete your consultation. But there's the trick. You have to build an approach in a certain way that as an FY2, as a PLAB 2 candidate, you tend to manage the situation in such an commendable way that the patient is also satisfied, and you were not able to convey everything that you could have, but still you are satisfied. And the thing that I did in the exam was, it did work for me, and I for the people I actually tried to help, it worked for them as well. It helped them maintain their calm, because maintaining their calm, maintaining your nerves, calming them down is the key of the exam. Because if you are tensed, if you are terrified, if you're scared, you won't be able to gather all the information and survive all that 8 minutes. So what I did, once they'll have the portion of the exam where you have to read the station, just read it thoroughly, read it once, read it twice, read it thrice, and try to make your differentials then and there. Like for example, if you have got a chest pain patient, there's a person, this and this age patient came to the OPD, came to the emergency or whatever, has complaints of chest pain. And according to the age, try to taper down, okay, what could be the diagnosis here? The diagnosis could be chest MI, the diagnosis could be pleuritis, the diagnosis could be costochondritis, the diagnosis could be pericarditis. Okay, you've got 4 to 5 diagnoses. Now, once you get on in the station, you have to rule out all these diagnoses, which are 4 to 5 according, it may vary from case to case. And once the bell rings, you have to go into the station, sit down, scout the room in an impeccable way in order to get, okay, is there any mannequin? Is there, okay, does the patient have any charts? Is there any instrument kept there? Is there anything else which I need to see? Is there any examiner? Just scout it in like 10, 20 seconds and sit on the chair. And just to make sure that you have all the things right, there's also the same paper, which is at the entrance. Placed at the left side of your chair on the table in order to make sure that if you want to review it again, you can always see it and nobody's going to mind, and it's not like a bad thing if you want to see the task again. So once you sit on the chair, scout the room and take a deep breath. Once you take a deep breath, exhale and then clear your throat, because once, if you're quiet for long, you tend to have that squeaky voice. And it's a very small thing, but it actually works, because once you start a conversation and you get that squeaky kind of voice, it actually, lowers down your morale, lowers down your confidence, and you have to give your 100%, and you don't have any window in order to make any mistake. So sit down, take a deep breath, calm yourself down, clear your throat, and then sit. Hello. Just start on with a very original and very cheerful smile in order to comfort the patient, because the patient, you're doing this thing for 16 stations back to back, 1 or 2 stations of resting stations, but you're getting different cases, you're getting different approaches, you're getting different scenarios. But the patient you have, he has been doing the same station for 16 times. Think of the stress he must be in. So he wants to be comforted, he wants to be calmed down. And that's the thing, that smile, that approach, the way you say hello, that basically signifies, that basically comprises, that basically summarizes that how your station is going to go. The best the introduction, the more the marks you get. Okay, so just say hello. If it's a breaking bad news kind of a station, if it's a counseling station where you need to lower down your chirpiness, that's absolutely perfectly fine. But if it's a history taking stations, if it's a counseling station where you're not supposed to be so low, where you're not supposed to be so serious, you might as well open with a bright smile and go accordingly, because smiles actually matter. Even if it's under the mask, it's actually visible. So yeah, just go on, say hello, try to think of it as a conversation. Try to think of it as a friendly discussion between a doctor and a patient. Do not think this is a consultation, the actual consultation, because the rules of a conversation is you say hello, let the other person reply. You introduce yourself, then you confirm their identity. Like, hello, my name is Dr. Shahbaz Ansari. I'm one of the doctors in the department. Could you please confirm me your name and age? He confirms me his name and age, and just pay a very good salutation. Okay, so how may I help you this fine day? Or how may I help you this fine morning? Okay, what brings you to us today? Whatever works for you. If you have better statements than me, if you can just open up in a very warm way, that's perfect. So this, and a lot of people tend to ignore the introduction, because introduction is something which actually gives a portrayal of you. Like, how is this consultation going to be? Is it going to be a bit, because a good introduction is equal to good amount of confidence, and hence you tend to take over the control of the situation from the very beginning. So this is how it goes. And in the face-to-face stations, you might as well get slided by in the introduction, because there your body language is also working, your hand gestures, the way you move, the way you sit, everything works. But in the telephonic consultation, everything matters on the start. The initial 30 seconds is where you basically get the grip of the situation, because the hand gestures, your emotions, your facial expressions, the way you sit, it does not really matter, because your voice is being thrown on the other side of the phone. And if you have a calming voice, you will get everything out of the patient. But if you tend to lose the grip in the initial 30 seconds, your station is lost. And it's in the 8 minutes, it's very difficult to get the grip over the station. So yeah, just work on the introduction. So this session will be an overall approach, and the telephonic consultation and the other mannequins and examination will be done on the later on session, because this session will be 40 minutes approximately. So I cannot cover everything into the 40 minutes. So good introduction is the key to success. Introduce yourself in a good manner. And once the introduction is done, and give pauses. Hello, hello. My name is Dr. Shehbaz Ansari. I'm one of the doctors in the department. So how may I help you? They say it, and then you say, okay, so you've got chest pain. As you said, could you please tell me more about it? So the way you say, the way you shrug your shoulders, everything matters, because the patient needs to feel that, okay, you're important, and he wants to hear you. The doctor wants to hear you. Then you would say, okay, I've got chest pain, I've got it here, I've got it here. And most of the time, once you say, could you please tell me more about it, he tends in 90% of the cases, the patient will vomit out every piece of information that he wants to give you, because he's an actor. The role he's playing is of a patient, and everything he tells you is scripted. He won't go away from the script. But because he's an actor and he's been rehearsing the same line over and over again 16 times, so just to make sure that he's being entertained, he might as well spice things up. So if you are good, if you tend to be very confident, he might as well give you a hard time. But the moment the simulator realizes that a doctor is struggling with the confidence, with managing the situation, he might calm himself down. So do not think that the patient was giving you a hard time just because you did a station bad. It might as well be on the opposite, that, okay, since the doctor is so good, I might as well give him a hard time in order to gather all the confidence that he have, and let's see how far he could take it. So yeah, and this same goes to the angry patients. They'll be immensely angry, but the moment you raise your voice, he'll lower himself down, because then basically he was testing you and you raised your voice. It means you do not have any calm. In the real scenario, even if you get that patient, you will be shouting at him. So just try to maintain your calm, so you can manage the situation in a very calm manner. Okay, so introduction is done. The presenting complaint needs to be evaluated. Could you please tell me more about it? After that, if you have gathered all the information, if you've gathered all the required data in order to ensure that the diagnosis you were thinking is right, it's perfect. You're not supposed to ask any more questions regarding the presenting complaint. But if you think that, okay, I need to evaluate a bit more, maybe a couple of questions more in order to solidify my diagnosis. Like if I had the patient with chest pain and he is complaining of chest pain, and I'm suspecting of something like MI, he tells me everything, but he's not mentioned any radiation of the left arm. He has not mentioned any diaphoresis. He has not mentioned any vomiting or diarrhea. He has not mentioned anything else. So I'll be asking those important questions like, could you please tell me, were you having any sweating? Could you please tell me that, is the pain going anywhere? So just 1 or 2 questions in order to solidify your diagnosis. And after that, the other diagnosis that you have in the differentials, like pericarditis or costochondritis, just ask 1 or 2 questions for the other diagnosis, which can be in this patient as well. So ask 1 or 2 questions and rule them out. So yeah, once your diagnosis is done, just finish the presenting complaint and the history of the presenting complaint. So that's done. Just turn the page over and go to the family history. Because, okay, if a person comes to you with the MI complaints and you have all the data in order to make your diagnosis confirm. So why would you ask all the questions? Why would you ask, okay, for example, in TB, weight loss is positive, low grade fever is positive, appetite, loss of appetite is positive, cough is positive, for a very long time it's positive, and all of this, any swelling, it's positive, there is any other complaint. So you've got all the positive points. You've got all the positive points. So why would you want every thing to be positive in a patient? That's not necessary. So once you have all the important data, in order to make sure that the diagnosis that you're making is good, and just ask a couple of questions in order to rule out other diagnoses, that's done. Just roll over and go to family history. And family history and medical history, like, are you diagnosed with any medical condition? And a couple of doctors do that. If they tend to ask, could you please tell me, are you diagnosed with any medical condition? They say, the patient replies no. Then they will ask, okay, any hypertension, any diabetes, any asthma? So why would you waste another question? Once the patient has said that no, I don't have any medical diagnosis, so yeah, just believe him. Do not counter question him. Do not ask him again any medical diagnosis, any medication that you're taking. If he says no, believe him. Yeah. After that, any medical conditions running in the family? Are you allergic to any medicine or any other thing? If he says no, skip. Because for us, it's important. For them, it's the information that they've been told, that they know since very long, because this is not the first consultation that you're doing. So yeah, if they say no, just believe them and move on. And one thing, I'm sorry, I forgot. Once you're transitioning from history of the presenting complaint to family history and medical history, just signpost this one thing, that okay, I'll be asking you some questions regarding your medical history and some questions regarding your lifestyle, in order to get a better insight of your current clinical status. Because you're transitioning from one set of the question in order to the other set of questions, and the patient might actually ask you, doctor, why are you asking me all these questions? Could it be related? So you have to evade that situation, because the thing that you're asking does make sense, but the patient does not know. He's not aware of the gravity of the situation. So he will ask you, and you will be able to answer him, that's for sure. But it'll waste your time. It'll be a waste of an effort. So try to evade all these scenarios and just prepare for everything in the start. Signpost one time, ask all the medical and surgical history if necessary. So you can ask surgical history. If not, skip. Then ask family history, medical history, allergies. After that, since you have signposted already, you can just dive into the lifestyle history as well. A lot of people tend to ask personal history. Well, what do you mean by personal history? It's a lifestyle, right? A person smoking, it's his lifestyle. So it's upon you, the word of choice that you want to have. But to me, lifestyle does sound a bit professional. So since you have signposted, just ask, could you please tell me by any means, do you smoke? Or could you please tell me, do you smoke? Whatever works for you. And try to be polite. Try to be nice. Just evade from asking direct questions. Because a lot of time doctors tend to ask, do you smoke? Do you drink? Well, if I drink, how is that your business? So just try to be polite, because this is the information that you want to gather. Okay, so you have to be a bit nicer about it. Just ask, could you please tell me, do you smoke? If he says no, skip. But if you think that okay, he must be saying something else, so you can just explore a bit more. And after that, and if you think that the scenario might actually help you with the situation, and the condition might actually change because of his information about smoking or alcohol, you might explore more. But if you think it's not necessary, just skip. Do you smoke? By any chance, do you smoke? By any chance, do you consume alcohol? So it's done. And after that, you can ask any what do you call it, travel history if necessary. If not necessary, just skip over it. If you want, if it's a female, you can ask if you have you can ask about menstrual history. Could you please shed some light on your menstrual history? If it's necessary, like a female patient with chest pain, depends what kind of chest pain is it. If you're suspecting something called PE, it might be associated, but if it's chest pain, if it's costochondritis, so I don't think so it's necessary to ask about menstrual history. Once that's done, you can ask about traveling history. You can, if it's necessary, you can ask what do they do for a living. If it's necessary, you can ask their social or home status. How do they manage the finances? If it's an old patient, if so you have to, it's important to ask who are they living with, and how are they managing the finances? Do they need the social support? So yeah, these are the very important things that people tend to miss out. If it's an old patient, social history is very important. Trust me, social history is very important. After that, so all of the medical history and all of the relative history is done, which is very important. If you think that something might be important and might help you in the management part, it might help you in addressing any things, you can ask. But if you think that information regarding his traveling does not make any difference, so why bother asking? So yeah, just skip everything. And once you're concluding history, just politely say, oh, thanks a lot for giving me all of the history, but by any chance, if I tend to miss on anything, or if you want to add on anything, could you please do that? Or do you want to add on something? Just wait. Let him speak. If he wants to say something, let him say. Okay. And after that, just thank the patient. Oh, thanks a lot, Mr. So-and-so, for that information. Now I would like to proceed to the examination, but I would like to examine you. I would like to do your vitals. I would like to do your vitals, do whatever chest examinations. And yeah, and always say that I would like to do a chest examination. For that, I will offer you a chaperone in order to ensure your privacy, because it's very important. Because if the person says that, doctor, do you mind if I have a chaperone? So that's something comes out of the blue. So in order to skip that, in order to evade that situation, just offer it initially, because a lot of doctors tend to say that, okay, I will say it when it's the time, but they don't tend to practice upon it. So whatever you don't practice in the practice sessions, you won't say it in the real exam. So yeah, if it's a chest pain, just say, I would like to examine you. I would like to do your vitals. I would like to examine your chest and do a chest examinations, your chest examination. And in order to ensure your privacy, I would like to offer you a chaperone as well. I just wait for a couple of seconds and he might give you some findings. And the good thing about this is, sorry, not the good thing. The bad thing is that you have to be very specific over the findings, because for example, if in the chest pain, you want to do abdominal examination. Okay, you did vitals, you did everything, and general physical examination as well you did, but you did not do the chest examinations, which actually has the findings in it. So if you don't say the proper word, if you don't say the proper examinations, you won't get the findings, because the people which are sitting as a simulator, they are not doctors. So they've been told that if doctor says this word, give him this. If the doctor says that, give him that. So yeah, try to verbalize every possible examination that you want to do, or in the examination which you are suspecting a finding. So yeah, that's done. And at times the investigation and an examination are in the findings are in the same paper. So just try to verbalize it in a sequence. Like, I would like to examine you. I would like to do a general physical examination, take your vitals, and do a chest examination. And in order to ensure your privacy, I would like to offer you a chaperone. And after that, I would like to do order a panel of investigation, which will comprised of routine blood investigation, inflammatory markers, a chest X-ray, a 12-lead ECG, and cardiac troponins. So you're verbalizing everything in a sequential manner, so you don't forget it, and you're verbalizing everything where you're expecting to have a positive findings. And once it's done, the patient might give you the findings accordingly, but you have to be very sure that you've said the right word. And don't just assume that the patient will give you something when you say this or when you say that. Okay. After that, since the patient might give you a finding, just scroll through it, read it thoroughly, and just keep it done. And once this is done, just ask, okay, I've done all the necessary investigation and examination. By any chance, before me starting your management, or before telling that I'm suspecting this, do you have any ideas about what might going on? Do you have any particular concern that you would like me to address during this consultation? And this is the portion of IC, and E. Well, I do not prefer doing E, and that's why I skip on doing E, because I'm not comfortable with the E aspect of the ICE. And if you tend to do ICE in this scenario, well, you've gathered all the information, you have done all the examination, you have done all the investigation. So you have all the necessary information, and you have got the arsenal of arguments in your hand. So what you're going to do is, now the part here is you doing the talking. So you have to gather all the necessary ideas and the concerns that you would like to address. If you don't do ICE, the patient will not give you his concern, and once you are done talking, he might throw something at you. So he also says that I've got this idea, I've got this concern. Okay. And if you can address it, just address it then and there. If you cannot address it then and there, you can just acknowledge it. Okay, I can see that you're really concerned about this thing, but let me just go through it, and I'll be answering your concern accordingly. So you have acknowledged the patient. So yeah, once this is done, okay, from the information, and now you're just breaking the news. Now you're starting with the management. Okay, from the information that we have gathered, and from the information, from the knowledge that you have given me, and from the findings that you've gathered, we are suspecting something called this and this. We are suspecting. So whatever you're doing, it's a suspected diagnosis. You're not supposed to say we have diagnosed this. So you're not making the diagnosis, your senior will. So yeah, we're suspecting this and this, and pause. Let him say something, and then answer it accordingly. Try to explain, and always give the word. Like, we are suspecting something called myocardial infarction. Just say the word, then explain it. Do not explain when you're saying the word, because that's the rule of the conversation. You tend to say something in the natural manner, and then if the patient wants to ask, then you will answer. So yeah, after that, explain the scenario. Just ask them what they want to do. What do they want to know what you're going to do about it? And after that, it's the talking game, and then the patient will tell you everything, that every question that they want to be answered. So yeah, what you're going to do about it? Are there any precautionary measures that you have to take? And once, try to be concise. You're not supposed to say that, okay, you're going to give him clopidogrel or you're going to give him aspirin. Just say that I'm going to give you some medications for this and this, and I'm going to do this and this. And after that, I'll be referring you to a certain department which will take care of you. And in order to make sure everything's fine, I will be involving my senior as well. So no table is left unturned. So done. Drop your lifestyle modification, do the safety netting, and thank the patient, and voila, you're done. And do not worry if you are not able to complete the whole scenario in 8 minutes, because it's impossible. It's to be very frank, it's very impossible to complete the scenario, because you're having a conversation and you can never predict how the conversation goes. So yeah, this is a nutshell of how the approach should be overall. Okay, and all of the DDs need to be ruled out, or important emergency ones alone? Well, that's a really good question, Dr. Jade. I would advise you to rule the emergency ones out first, because everything after that emergency can be dealt with in a very calm manner. So yeah, just try to rule out all the emergency one, and whatever the DDs are very generic. So you're not supposed to rule every DD, but you are supposed to rule out every possible diagnosis that you have in that particular scenario. From the history, it's clear cut, it's MI or TB. Yes, most of the time it is. Should I rule out other pneumonia? If you think it might be cancer, you can. But a young patient, cancer is very unlikely. In history taking, we have to do a systemic review as well, or we can, well, it's not necessary, doctor. It's an 8-minute station. It's not an MRCP kind of exam. So you're an FI too. You're not a consultant. So the cases that you have will be very generic, will be very common. You won't actually get something called osteoblastoma, or you won't actually get necrotizing fasciitis or something like that. Okay, a little random question. Can you have a beard while practicing? Oh yes, I went like this. I went like this. You can have a beard. Should we ask about social history? Well, in a patient who is old, in a patient who you think the social history would actually matter, like most of the patients in a psychiatric station, most of the patients living alone, old patients, yeah, social history is very important. And even after that, in abuse cases, in cases where you think the patient, it might be delusional, if the patient might be depressed, so social history is very important, but it varies from case to case. Like if a patient has come with costochondritis, I don't think social history matters. If a patient comes with any other complaint with, for example, gout, social history, I don't think so matters. So yeah, that varies from case to case. In history taking, okay, that's, I think I've answered. The beard question is done. Oh yes. Any other questions that you doctors want to ask? I'm here. And one small thing, from the history taking station and the counseling station, the time management. I would advise you, and this is something I did and it worked for me, and this is something I advise my other colleagues as well, and it worked miracle for them. In a management history taking station, try to incorporate a history of 4 minutes max. 4 to 5 minutes of history in history taking station where you're making the diagnosis, and rest of the 3 to 4 minutes is for management, because everything does have equal marks. So why are a lot of doctors giving less importance to management? So yeah, the time management should be like this in the history taking station, whereas in the counseling station where you are doing all the talking, in that station, to be very sure, the diagnosis has already been made. So what information can you ask at an FI2 level which can change the diagnosis? Well, I cannot ask anything else in order to change the diagnosis. So try to ask a very short history when you're counseling. It should be around 2 to 3 minutes, and rest of the time, which is 5 or 6 minutes, should be kept for the management part. Yes. Should we start with the chest examination if I'm suspecting? Well, that's the thing. Try to say, I would like to examine you. I would like to do a general physical examination, take your vitals, and then do an echo chest examination on this and this. So yeah, I think I've got less than 1 minute, and I think I tried to convey all of the information. If you have any questions, you can always hit me up on Instagram or on WhatsApp. I'll be sharing my Instagram link as well. And you've got my WhatsApp number in the group. It was really nice having you people. I hope this session was fruitful, and looking forward to meet you people again. So till then, bye-bye and good night.